Welcome to our afternoon series of sessions here. We're going to be back here for this plenary environment, and I hope you all had terrific breakout discussions and sessions and learned some things and thought about some new ideas. What we're going to do now is engage with our state lawmakers in Oregon to talk about the legislative parts of our health policy agenda. As you know, this is going to be a complicated session, so what we're hoping to do is kind of get started, talk a little bit about this year and what it might indicate for next year, but also some of the issues that you all have been discussing in the various sessions. So I'm going to start off, though, by reminding us of some things that Claire Pierce-Warble said this morning from OHA. We have almost 1.5 million Oregonians on the Medicaid program in Oregon. We have, which is about 32.5% of the population, very significant number of people there. We, of course, have the smaller number, but still significant, 145,000 enrolled in the exchange, including the basic health plan. So this is a lot of the population we're talking about is enrolled in public programs. But as we've been talking about throughout the day, there are lots of pressures in public and private coverage as well. We have economic challenges, we have growth issues that really do put a lot of stress on our private healthcare coverage and systems and affordability. So we're going to talk a little bit about that. We're going to roll up some of the things you all have been talking about throughout the day, workforce challenges, primary care, affordability, and really look at it through the legislative lens. So I have three speakers. Well, I will have three speakers. I have two right now, and we're working on the third. We have Senator Deb Patterson, who is the chair of the Healthcare Committee in the Oregon Senate and represents District 10. I have very good, thank you. Fan club is here too. Representative Ed Deal is vice chair of the Healthcare Committee in the House of Representatives and represents District 17. And soon to be arriving on stage, Representative Travis Nelson is also vice chair of the Healthcare Committee in the House and represents District 44. Okay, so as we do in these sessions, we're going to do a couple of things. We're going to start with a conversation. We're going to really talk about our agenda and what you all see as really driving your activities going forward, and maybe some things from this year's legislature. So let's do a little bit of a look back. What were some of the things that you did in this previous session? I know that I was reading the news and there was a lot of focus on transportation near the end, but let's go back a little bit further from that and talk about some of the health-related legislation that you supported in the previous session, and maybe where you left it, where you feel it resolves now. Where does it sit now? Are there things that you intend to bring back, things that are unfinished? Looking a little bit backwards. I'm going to start with you, Senator Patterson.
Well, thanks so much, Kathleen, and good afternoon, everybody. It's really a pleasure to be with you here this afternoon, and nice to see you again, Representative Deal, and I know Representative Nelson will be joining us momentarily. One piece of legislation that my office and I and others had worked on together for quite some time, and I'd like to mention two of them. The first is Senate Bill 296, the hospital discharge bill, because it grew out of the pandemic where we had hospitals that were overflowing, bursting at the seams, and people couldn't move into the appropriate level of care following that. And so we worked for a little over a year, a broad coalition of folks, hospital, long-term care, home care, and others, to take a look at the challenges. And I'm really happy to say that because of this, we created a dashboard to improve timeframes for eligibility determinations for long-term services and support, and directed ODHS to study innovative care frameworks and expand the post-hospital benefit from 20 to 100 days. And I'm really happy. Ruth, I saw Ruth here from Salem Health. Ruth, where are you? I know you're here. There you are. Ruth Miles, and yesterday as we visited with Cheryl Wolf, the CEO, and Leah Mitchell there, reporting that there is some real progress being made in hospital discharge. So much left to do yet. We didn't focus specifically on certain types of complex medical needs, such as brain injuries and others. And we also we're going to have in the informational in January in the Senate Healthcare a look at how this bill is being implemented to make sure it works. And the second is Senate Bill 951 worked closely with Representative Leader Bowman to protect patients from the profit-hungry investors in healthcare. And so the corporate practice of medicine bill, which keeps healthcare decisions in the hands of healthcare providers. And so I can speak more about that later if you want, but those were two important pieces.
Yeah, and the complex discharge, such a challenging space. You know, we've been working a project in Washington State around that same issue and the availability of community services. It's a terrific thing to take some cuts at and then come back and see what's working and what's not. So that sounds like a really terrific way to come at it.
And I would just like to add that hospitals and other providers obviously are working on this and themselves. And Salem Health is a really innovative model in that folks with complex medical needs who are ready to discharge now are being moved into a special unit where they can be appropriately cared for as they wait for discharge. So lots of innovative things happening growing out of it. So I'm really excited about that.
Wonderful. Thank you, Senator. And welcome, Representative Nelson. You missed the applause line when I introduced you, so if everybody would replicate that briefly, thank you.
Yeah, do it again. Thanks for having me. The joys of having a day job on top of this job, tell you.
Understood. And I'll repeat the question when we get back to you, but first, Representative Deal, do you want to talk a little bit about what happened in the previous session and what you want to put on the table for today?
Yeah, you bet. Well, a lot happened. So, you know, I look at we did, you know, the 340B changes, we did the provider tax renewal. The senator talked about the corporate practice of medicine bill. I'm not a fan of that bill. If you want to drive consolidation and have hospitals own all providers, that was your bill right there. And it's going to stifle innovation, which is something we need. But there's a lot to talk about on that. But I'll talk about the bills that, some of the bills that I introduced myself. Some were successful, some weren't. But one was House Bill 3242, which was credentialing. So we brought a bill to require health insurers to reimburse a provider at in-network rates during the credentialing period. And we got a lot of support with that. It just makes a lot of sense. Some insurers were already doing it, so we were pretty happy with the way that went. We also introduced House Bill 2540A, which was a direct pay bill. And I really like this. You might view it as a small thing, but what it does is allows someone to use cash, go to a cash pay provider, and that can go against their insurance deductible. If it would otherwise be covered, you know, if it's part of their insurance plan, if it would be covered, they can use that cash pay. And the reason why it got a lot of bipartisan support is because it does save money. Mm-hmm. So I'm really excited about that one going through. House Bill 2596. So if you've ever hung out with me in the legislature, you know I like licensure compacts. Rep. Nelson and I have a lot of fun talking about licensure compacts. So I've brought a number of compacts to the legislature, and I think probably most of you know how those work. But I think it would be an advantage, a tremendous advantage for us when it comes to staffing to be part of the compacts that our neighboring states, in some cases that the majority of states are already part of. Well, I've hit a roadblock on every one except House Bill 2596, which I signed on to, which would have brought the School Psychologist Interstate Licensure Compact to Oregon. It cruised through the House, it cruised through the Senate, and then the governor vetoed it. So I still haven't had my discussion with the governor as far as why, but it's clear that there's an aversion to compacts. And I think that's at our detriment. The country is adopting compacts all over. Oregon's going to get left behind if we don't, and we're losing talented people because we are not part of compacts. Another one that I worked on was pharmacy reimbursement reform, the PBM bill, and put a lot of effort in there, but there's just a big divide between the different groups on how we do that. But we know we have a problem, especially with rural pharmacies, with the reimbursement structure, and we need to fix it or we're going to lose some more pharmacies. So I'm still committed to working that issue.
You know, you noted about one of your comments that it wasn't a big issue, it was sort of a smaller fix, but it seems like that's what we need, a lot of smaller fixes sometimes to get to the bigger fixes. So I really appreciate the full list.
I agree. We have some real challenges already in healthcare. HR 1 has introduced some more challenges, especially for states like Oregon. I'm trying to view that as an opportunity, and I know we're going to talk more about that.
We're going to talk about that, yeah, absolutely. So welcome. We were starting sort of looking back to last year. Anything that you wanted to return to that you're still working on that's maybe still bothering you, or maybe that passed that you're really excited about? Take a look backwards for us.
I don't know that you want to hear me talk about what's still bothering me. There's a lot there. And for the record, you all heard Ed Deal say there were problems with the big, beautiful bill. I'm just saying.
I don't think I said problems.
Challenges.
Some challenges.
Challenges. Okay, all right. So last session, our office had what we perceived to be a pretty successful session. For those who don't know, I'm a registered nurse. I've been a registered nurse for 20 years now, have worked in a variety of settings from the ER to the cardiovascular ICU. I was the head nurse on the inpatient rehab unit at Peace Health Southwest for a couple of years and did case management and am now mostly working on the health policy, health labor side of things in Washington State. But our office put forth House Bill 2741, which passed. That's a bill that updated newborn blood spot screening, and basically it includes sickle cell in that and requires that parents be given information when their child is diagnosed with a genetic disease like sickle cell at birth, about the different organizations that work with folks who have that type of illness. So, for instance, at birth, a child born with sickle cell should be connected with an organization like the Sickle Cell Foundation of Oregon, and so that's one of the aims of that bill. I have another bill, House Bill 2940, that was passed. Another bill related to sickle cell. Worked with the Hospital Association on that, the Oregon Nurses Association, and others. It was a bipartisan bill related to sickle cell again. A big challenge that we have in our state is we don't have a lot of people who have sickle cell here. It's mainly a disease that affects African Americans and Hispanic Americans, and when they go to the ER, their pain is oftentimes interpreted as drug seeking. So this bill that was passed should, using a system in ERs called the EDDI system, flag for providers that these are sickle cell patients and not drug seekers. I'll try to be brief because we had several wins. House Bill 2942 related to PEP and PrEP just takes another step in ensuring that pharmacists who are prescribing it are actually getting reimbursed. House Bill 2748, which was a nursing title protection bill as it relates to AI, ensures that titles like certified nursing assistant and registered nurse are only used by humans. House Bill 2789 will allow nurses to be reimbursed for coordinating care. House Bill 2948, Hannah's Law, ensures that only nurses are supervising school nurses there's a bigger story there. Ask me about it. There was a child that was harmed because an aide was doing nursing care, and that child was harmed for the rest of their life. And the parents approached me about bringing a bill, and with bipartisan support, that bill passed. There was also Senate Bill 537, healthcare worker workplace violence protections. Worked on that bill with Deb Patterson, and just takes another step towards ensuring that our healthcare workers are protected from incidents of violence on the job. And then House Bill 2024 was a bill that did similar things but was aimed at behavioral health workers. Worked in coalition to get that done. And yeah, those are some of the highlights, and very proud of those bills that we were able to get across the finish line.
So, you know, a lot of this work was done as the federal dynamics played out as we moved forward. So let's turn our attention now to what's coming up. Short session. So I'm relatively new to the Oregon space. Never heard of a short session. I come from Washington, D.C. I wish there was such a thing as a short session and in that context. But as we think about the challenges that are out there, and as we approach this upcoming session, how are you all thinking about prioritizing handling this short session in this environment? What are the opportunities? What are you concerned about won't make the docket that needs to? So I'm just kind of throwing this wide open for how all the rest of this room can think about supporting you and going into this session. Who wants to go first? Oh, Senator, please go ahead.
Yeah, I'm happy to say, as you know, during the short session, we each get 2 priority bills. And so I'd like to continue the work that we did on the corporate practice of medicine by expanding that to hospice. As you know, in California, as many of you know, they have a moratorium on new hospices coming into the state due to some reporting in the Los Angeles Times of some real egregious practices that particularly for-profit hospices were doing, preying on the dying, essentially, for profit. Washington State has a certificate of need. I have a bill that is looking at rather than either one of those, rather than a moratorium or a certificate of need, but quality-based licensing criteria, so we can be sure that the hospices that are coming into Oregon, and they're coming in quickly because there's a longer process in either of the other western states, coastal states, to assure that the people who are on their last days are receiving quality care. And also, the challenge and the opportunity that HR 1 provides to us, and I would call it both, I think, also requires us to look at our spending in healthcare and who's getting the money. And so one of the committee bills that I'll be bringing is related to looking at the reimbursement model and the utilization for primary care providers, and trying to put together a task force of primary care providers and those who work with them to look at this, because clearly, as the universal governing board for universal health care, I see Healthcare for All Oregon is here, and as others are looking at how do we make healthcare more affordable. The cost growth target's part of that, obviously, but the primary care physicians are crying out for help. Please help us stay. Recently in Salem, 10,000 patients lost access to primary care through the Salem Clinic. So this is an urgent issue, and so that will be one of my upcoming bills as well through our committee.
Representative Nelson, I'm going to hop down to you.
Sure. So as Senator Patterson stated, we have 2 bills each as legislators for the short session. Neither of mine are going to be directly healthcare related. I've got a bill related to improving protections for folks with disabilities in the workplace, and a bill related to cashing out earned PTO and vacation time that I'm looking at bringing. But as far as the theme for the short session, I think access, doing what we can to stabilize CCOs that are doing great work across our state, and also doing all that we can to mitigate for the impacts of the big, beautiful bill. We are a state that's going to be very challenged over the next couple of years. We were already going to be challenged, and from my perspective, the big, beautiful bill made that even worse. So ensuring that those who need health care the most have access to it, ensuring that people aren't dying unnecessarily because they can't get OHP, those are the things that weigh on me day in and day out.
Thank you. Representative Deal, you used the word opportunity, as did the senator. Talk to me a little bit about both sides of that coin here.
Sure. I'll talk about one bill that I'm going to plan on introducing, but there's a fairly new designation for rural emergency hospitals. I think it's an opportunity for us to use that designation and hopefully be able to provide some more financial stability for critical access hospitals and other ones that are designated as rural. So hopefully we can make that happen. But I think the majority of our time is going to be spent stabilizing, I'd say stabilizing or right-sizing our Medicaid system. We have to realize that I know H.R. 1 is throwing a curve into a lot of Oregon's plans, but we already had a problem. We saw that when we have our price controls or our cost structure and the CCOs. There was no way they could operate within those cost increase structures. And so what I see us doing, I put it this way. We have this grand desire to expand Medicaid to a huge population, but we're not willing to pay for it. And the way we're paying for it right now is in debt, federal debt. Half of our state budget is on social services. Half of our budget. And a lot of that comes from the federal government, and it's debt financed that my children and my grandchildren have to pay for. And I don't think that's right. I don't think we should be debt financing social services. You can debt finance a bridge, you can debt finance a war, you cannot debt finance social services. It's unsustainable. And so I think what we're going to have to look at is, with our Medicaid system, what adjustments do we need to make? And just frankly, we reimburse, I'd say we mandate steak and we reimburse at hamburger rates. And everybody knows that. So we have to look at what opportunities do we have to cut our costs for providers. A lot of that has to do with regulation that our state has put in place in the past that makes it especially difficult to do business in this state, and we hear that. And also look at what we cover. Maybe we need to reduce our scope of services. And I'd love to get into more detail on that. I see there's a lot of knobs I'm willing to turn, and there's some other knobs I'm not willing to turn. But that's probably the biggest thing in front of us in the legislature, is how we stabilize that Medicaid system. And it has a direct impact on the private market, too.
Yeah, and we are going to have an opportunity for questions from the audience in a few minutes, but I want to sort of pick up on some themes that you've already cited here and that we've heard in other contexts about, we talk about H.R. 1 or OBBA, I can't remember, there's a lot of B's in it. But when a lot of conversation has started there, we start there but we need to recognize that most of the consequences of that bill are several years down the road. And you all have been talking about issues that exist right now and an opportunity that exists right now try to do what you can to both ameliorate, but also shore up might be a way to see it. And what you're saying, Representative Deal, about where we are now, when many of these consequences are coming down the road, what are our opportunities right now to do what you're describing? Because I do think that that is what we're hearing a lot of states try to deal with, is what can I do right now? I want to get into the rural health funding in a second, because that's the rosier side of some of this, but really on the side of the consequences, most of the consequences of HR 1 shifts come down the road. What are the opportunities to address it right now? Anybody?
Wow. All options, I think, are going to have to be on the table. There's discussions that are starting now around that, but I do just want to say that these cuts didn't have to happen. The cuts in the big, beautiful bill, let's be frank, it's a backdoor takedown of the Affordable Care Act, Obamacare. This is something that has been in the works for years, rolling back subsidies, cutting people off of Medicaid. In my opinion, the United States government, #1 priority should be to ensure that the citizens are safe and healthy. And if our government isn't doing that, then what's all of this really for? The money is there, right? Like, we just gave $40 billion, the president just gave $40 billion to Argentina. Half the White House was ripped down, and there's a $300 million ballroom that's being put up. Money is being spent left and right. Our national debt, the trajectory of it in the last few months has gone from being like this to being like this. The money is there. When we want to spend money on things as a nation, we find the money for it, and we need to find the money for the people. And that's why I ran for office, and that's why I'm going to keep fighting day in and day out, because we have to put people first, whether it's the federal government or state government.
I would agree that HR 1 is an ideological bill. And we are the only developed nation in the world that does not provide universal health care to all of its citizens, and many countries also provide universal health care to all of its residents, not just its citizens. And some developed countries provide universal care to some of its visitors, not only its citizens and residents. So as a country with the vast wealth that we have, we really do need to be providing health care for all. And that's a moral question, but it's a business question. I mean, businesses are spending a lot of money providing health care to their employees that they could be investing in their businesses and growing their businesses. I just got back from China, which I realize has a very different model on with a legislative delegation. But I will say the businesses there are just going gangbusters. Their trade surplus is going through the roof, and everybody there has access to health care. So I think in this country, with the number of very bright people that we do have a moral obligation to make sure that we find that path forward. The governor does have an advisory board to look at the cuts that we're facing and how to best. I think we should be really proud of the fact that thus far, Oregon has achieved 97% coverage for health care, and so we do have close to coverage for everybody, but we have a bumpy road ahead of us, and yet sometimes those bumpy roads are the roads that get you to the place that you want to be, and hopefully we're going to get there together.
Well, a lot of thoughts there. So I'm a state legislator. I don't have any control of what the feds do. I just look, it is what it is, and we have to adjust to it, and what knobs can we turn? I'm just looking at it very pragmatically on that front. I would say that we have focused very much on coverage. It's very proud. We have 97% coverage. But that does not mean access to care. And that's what I want to focus on, is access to care. And that may look a little different than just making sure everybody has Medicaid coverage. But as far as the adjustments we have to make, frankly, we had to make those before H.R. 1 even passed. We were already at a breaking point. And so the knobs that we have, we can raise taxes, we can reduce scope of services that we provide through Medicaid, we can change eligibility requirements, which would reduce enrollment, and frankly, that's going to happen to us anyway, out of our control. We can reduce the regulatory burden on our providers. We can improve efficiency between state agencies and the CCOs and the providers. We can reduce reimbursement rates, and we can reprioritize dollars. But there's a few knobs that I'm not willing to turn. I do not believe that we can raise revenue. I think that's out of the question right now in this climate. And I don't think there's any chance we should even try to reduce reimbursement rates. That seems crazy. So that leaves the other knobs, which is seriously looking at what are the scope of services that we provide under Medicaid and eligibility requirements. And then look at some of the legislation that we passed that we know is driving up our costs without really providing any additional benefit to patients. And let's seriously talk about unwinding some of that or fixing some of those problems. And I could give you a list, but those are my thoughts. Thank you.
Maybe we'll get to the list next. So I am going to open it up for questions. I want to, as we're doing that, access is something you mentioned, Representative, and also the issues around rural health, which is a major part and very near term. We were hearing from OHA that they're hopefully are submitting on time, everything going well in terms of the transformation funding that is supposed to be coming down in the end of December. So the announcement should be coming in December. There's a lot of rural health opportunities. Anything on your docket in terms of either barriers that could be removed or ways that you're thinking about rural health and rural access? Any of you want to talk about that at all? So I open that up and then we'll open up for questions. Anything on the rural health front? Yeah, please.
Again, it kind of circles back to primary care. We've got to make sure we've got primary care access across the state. There are some places like Sweet Home that had like one physician associate trying to provide primary care. So we need to make that more available across the state. I'm really thrilled that we were able to pass the bill that allows community colleges across the state to offer 4-year RN degrees, and that's just rolling out now. But if you know anyone who wants to become nursing faculty, please tell them to keep going and do that, because we need those across the state. So the investment in rural health, though, is still just a drop in the bucket. We need, it's not going to go that far. It's 5 years, $5 million a year. When you think of the expenses of hospitals, I mean, back to Salem Health in my district, $2 million a day to keep that hospital running. And I realize there's not a Salem Health in the rural communities. They do have a rural setting out in Dallas and are working elsewhere as well. But golly, that money's not going to go very far. So anyway, primary care and more access to providers who are able to learn where they're at and stay and serve their communities.
I agree with the center on the primary care. That's a real problem we're facing. I hope that Oregon maximizes the opportunity with the rural health transformation. I know that we're actively putting grants together. I haven't seen the details on that. I don't know if we've...
They're not out yet.
Yeah, they're not out yet. But there's an opportunity to get even more money, but it is only a 5-year chunk. It's meant to implement new systems to fix problems. It's not going to be an ongoing, sustained dollar amount that comes to our rural communities. I think that we should be willing to think out of the box a little bit about when it comes to rural healthcare and healthcare in general. Telehealth. We need to look at those opportunities or options. We need to look at scope of practice. Where could we draw the line on scope of practice a little bit? Maybe Someone without a full MD degree can provide some services that, and provide those services in communities that are otherwise unable to get that care. I like the idea of, kind of a segmented model where primary care, we are seeing this already. We're seeing doctors enter cash pay systems, and they can provide services at a fraction of the price that they can through the regular sector. You got to ask, why is that? Why is it so different? Why is it so expensive to do it one way and not the other? That points to a problem with regulation and so on that we should be able to fix. So those are just some ideas. I really want to think out of the box and think about innovation. And that also includes technology. I know there was some AI talk earlier today on that front.
Terrific. You think, Dan?
Yeah, I will just say, well, first of all, I represent North and Northeast Portland in the legislature, so I'm not exactly rural, but I did grow up in rural southeastern Washington, not far from Hermiston, Oregon, and I know nurses who work in Hermiston, work in LeGrand, and those rural hospitals were struggling before the big beautiful bill was passed. I think they're going to have a much harder time now, just given the reductions in Medicaid. If you look at a map of Oregon and you see where people are getting Medicaid, disproportionately, rural Oregon is impacted. Hospitals in rural areas are already operating on tight margins, and I am very concerned that we're going to see a wave of closures, not just here in our state, but across the United States. And when you live in somewhere like LeGrand or Burns, your hospital means everything to your community. It's not just where you go for care, but those hospitals are also often the largest employers in the entire county. And so doing all that we can to work with the hospital association and stabilizing them is something that we have to keep our eye on as we're having this discussion about how we move forward with choices around Medicaid. They're probably going to be surprised to hear me say that, just given the fact that I've been pretty demanding on them and really believe that they need to be even more transparent than what they already are. But I know what small rural hospitals deal with, and they're struggling, and the legislature needs to be responsive to those concerns.
Okay, thank you. Do we have questions from the audience for our panelists? Things we haven't touched on yet?
Shy crowd.
Yeah. Somebody want to talk about scope of practice? Oh, we have a question here. Go ahead. Just a second, the mic is coming to you. Please introduce yourself too, please.
So my name is Leslie Parker. I'm just questioning if we're looking at pulling back some things from Medicaid. Do we have any idea of what those might be? If we're looking at their scope and saying, okay, we're going to pull some of that back or consider pulling that back, what would that look like?
Could I take a stab at that? Right now, the governor has assembled a table of the Hospital Association and others who are CCO representation, others who have a real stake in this issue. To discuss that, she's engaged Bruce Goldberg, former director of the Oregon Health Authority, to be a facilitator with that, assisting Christina Narayan. They're reporting also back to Representative Nose and myself and Senator Campos, who's the chair of the Ways and Means Subcommittee on Health Care, and I believe a couple of others as well. And their work just began a few days ago. Certainly, I think I agree with everyone here, is that I don't really see a path forward that doesn't involve some cuts probably to Medicare, but you don't want to cut off your nose to spite your face. So these would have to be cuts that would not affect population health and the well-being of the people who are on Medicaid. And the goal is to try to keep as many people as possible covered and with access to care.
See, the challenge, we talked about rural health care. You know, you look at the numbers, and for these hospitals with a large Medicaid population, their reimbursements are below their cost. It's that you can't sustain that. So if we're going to try and reimburse for the actual cost of care, there's changes we have to make, right? And I hope that we can find ways to actually reduce the cost of care and be creative and innovative there, because we do have a tight budget. We have a tight budget. And I hope when we're looking at the scope of the services that we're doing I'm really interested in what the process is that they will go through to do a cost-benefit analysis and really look and evaluate at where that line is drawn. So I have a lot of questions on that front. I know that some of the stuff is required from the feds. We have to do it. But there's other things in there that we definitely don't. And so I look forward to more discussion on that.
Thank you.
Yeah, I don't really have a whole lot to add. I think my colleagues covered it pretty well. I think there's going to be a pretty extensive look at cost-benefit analysis and where we are getting our best bang for the buck and what cuts will need to be made to get the best bang for the buck as well.
We have one all the way up front. Oh, here comes Kayla. Yep.
Thanks. My name is Valdez Bravo. Just a quick question. So when I was I did a master's in healthcare administration where we studied health systems and the whole, operation of healthcare in America. And the model that in America that we have, is FIDP. A lot of you in the room know this, right? Finance, insuring, delivering, paying. And it's funny, Rep. Deal, because I think you kind of made a case for single payer in the way you said that, like, why does it work so well when somebody just goes in with the cash and gets the care and walks back out? It's so simple. And that's true because the person walking in is financing it, the provider's delivering it, and the person's paying it, and you don't have a middle person dictating what care they get or taking a huge chunk of that money that should be going to the provider for providing the care. So my question is, since FIDP would just be FDP in the way it's happening more and more in North Portland and other places where doctors are moving to practices where they're bypassing the system, what hopes do you have for the Universal Health Plan Governance Board, which is a statewide body working over 2 years, appointed by the governor with 9 trained experts who are looking to move to an Oregon FDP model that would keep all the money we're currently spending in the system here in state, here in the system, and here taking care of patients?
The Universal Healthcare Governing Board is going to be presenting at our informational on November 17th, I believe. The dates were the ledge days are from the 17th through the 19th, and the meeting times were just announced earlier today, and I believe it's on Monday the 17th. But we're really excited to hear about the progress that they're making in putting together the financing model for how that would work. And again, looking at other countries, a model of having one payer does take about 15% of the overhead out. And the governor's asking the agencies to make cuts of 5 to 7%. 15% is double that, and that would really make a difference in healthcare. However, it would probably cut into some of the things like recently visited a health system, not in my district, where one of the hospitals had a wonderful lobby that looked a lot like a national park lodge. That's not seen generally around the country. The cost spent on healthcare is in those models is generally spent on providing healthcare rather than a lot of extra bells and whistles that make it a more like a luxury hotel. Nothing against the hospitals. I love you all. And you have also heard me say over and over, I do not want to see one single hospital in this state closed. And I stand by that. We've got to support every single one of our hospitals all across the state Every single one. We need them. We have one of the lowest bed rate per population ratios in the country. We need the hospitals. They're great. But we need to be sure our dollars are spent on care. Thanks.
We have one of the lowest bed rates in the country by design, so I think we might want to question, was that the right idea? Universal health care is going to cost us $10 billion, $15 billion, somewhere in that, right?
Less than now. Still less than we're paying now.
And I just don't see universal health care working on a state level. I just do not see that. If nationally we were going to do something, that's one thing, but on a state-by-state basis, I just don't see that happening.
So I was a co-chief sponsor along with Senator Manning of Senate Bill 1089, which was the bill that led to the Universal Healthcare Governance Board. And I'll just say I'm excited. I mean, I know we're in challenging times, but oftentimes it's darkest before the dawn. And this group is a group of experts. They are hard at work, and I'm gonna be tuning into the hearing over in the Senate Healthcare Committee. And I will, like I said, I'll be looking forward to seeing what that group comes up with. I think we've got to do something different. I think we've got to innovate. And big part of the reason why I ran for office to begin with back in 2022 was because I believe in universal health care. I was inspired by Bernie Sanders and the Medicare for All movement. And I'm on the board of Nurses for Single Payer. And I just don't think anyone should die because they can't afford to pay. My dad was a guy who worked himself out of poverty into the middle class. His grandparents were Louisiana sharecroppers, and he ended up dying because he had an illness that he put off. He put off seeking treatment because he was concerned with how much he was going to be charged if he went to the hospital. By all accounts, if he had gone to the hospital when he first started having symptoms, my dad would still be alive today, but instead he died 7 years ago from complications from diabetes at 60 years old. Too many people out here have stories like that, where loved ones have died unnecessarily because they have not been able to get the care that they needed or had fears about the costs of getting the care that they needed. And in the wealthiest country on the planet, in a state like Oregon, that just shouldn't be happening.
I have another question back over there.
We've talked today a lot about cost reduction and innovation, and part of that story has to include technology. We had a session on AI. From a federal perspective, Dr. Oz has been promulgating his ideas about how to use AI and has voiced that there are so many new things upcoming that he's excited about. One of the concerns that I have is in the rulemaking process at the federal level, they have excluded equity considerations from how they're deploying AI tools. And so I'm just wondering if that's something we're considering at a state level. If it's not going to be monitored from a federal perspective, how are we thinking about, as these new tools are deployed for cost savings and all of these other things, how are we ensuring that that equity is continuing to be considered?
Wow. Is it okay if I talk first? Is it okay if I
please.
Okay, all right.
I didn't know you were
Just wanted to
asking my
make sure
permission.
there wasn't some type of order in mind. From my perspective, we're behind the ball in our state on AI. I think most states are. This is technology that is quickly advancing. We are seeing huge leaps and bounds by the day when it comes to AI. A year ago, we could all tell, for the most part, what an AI video looked like. Now it's, in a lot of cases, damn near impossible to do so. Representative Daniel Nguyen had a bill that I was a supporter of that would have created an AI task force. Unfortunately, that bill did not make it across the finish line. That's one of my biggest regrets from the last legislative session. But we gotta get up to speed there. I'm not clued in as to what he's planning for the short session. I hope he brings that bill back, but the conversation around equity has got to be a part of that conversation.
Anyone else?
And I know that the late Senator Aaron Woods was spearheading a task force on AI with a mind to include a subcommittee, AI in healthcare, but he passed away. Senator Lisa Reynolds is picking up the ball on that, and I believe if it's, I don't know that it's going to be in Senate Healthcare, but it may be in her committee on early childhood and behavioral health, a session in the next information and ledge days about AI in healthcare. She's looking very closely at this issue, and so I think that she'll be picking up the baton that sadly Senator Woods had to set down because of his passing.
This is just a general comment on AI and industry and business. There's an opportunity for Oregon to be a leader in AI, and along with that, a leader in robotics. And I'm thinking specifically of OSU is building right now, I think it'll be the world's largest university-owned AI data center, right here in Oregon. We have the world's first humanoid robot factory in Oregon, in my district. And I think Oregon has an opportunity to really expand on this great talent that we have coming out of our university systems, amazing talent. We do a great job of incubating business. We do a lousy job of keeping them. But we have an opportunity to change that. I'd love to see it because that brings jobs. It brings good paying jobs, people that can afford health care. We have an opportunity. There's talk now about the Southern Willamette Valley Innovation Corridor. I've been involved in those conversations. I'm really excited about what that may lead and looking at how that's been done in some other states. So, and believe it or not, that's key for us to get out of this hole. We don't want to be, we're a high tax, high social services state. I don't want to be a high tax, low social services state. That's like the worst of both worlds. We need to create an environment where we have industry and business coming here and investing in Oregon.
Could I just pick up on one thing? I'd like to say I think I would disagree with you on one point in that I think no matter what job you have, whether it's a high-paying, high-tech job or a home care worker, everyone should be able to afford health care.
I agree with that.
Okay.
And I think it's a matter of how we get that done. We may not agree on, but I agree with you. Everybody should have access to care.
All right, I am ending this on a point of agreement. Let me say, what I've heard here today is a recognition from each of you that there's challenges ahead and that we have to come together or we won't move forward. And I think that those challenges, we can argue about whether they were necessary or not, but they're here. And you all are going to have the challenge in your next session of trying to tackle those. So we really appreciate you sharing your ideas and your time, and we will move to our closing plenary. Please join me in thanking our legislators.